Good morning, respected teachers, my seniors, and my dear colleagues. Today I am going to present the audit of the month of June and May. First, I would like to present the audit of month of June. So we performed 72 surgeries, among them 49 were major, 17 were minor, and 6 were intermediate procedures. 27 of our patients were male, 45 were female, and the age range was 15 to 82 years, with average age of 55 years. As well, the patient demographics. Female, they are 62.5%, and male, there is 37.5%. There is female patients comprise more of our cases. Age distribution, as the malignancy age increases as the age increases. 46 to 60 years comprise majority of our cases, and the old age, the most 61 to 82 are 26% because those age usually the patients are not non-operable due to other causes. The top districts, the Chittagong and the surrounding districts dominate our cases, with 20% of our cases from Chittagong and 8% from Rumbandai. The major procedures, we perform major thoracic procedures like we perform vast lobectomies, pneumonectomies, hysterectomies, vasectomies, meniscopy, and thymectomies. We are increasing our minimal approach with more bad cases. GI and hepatobiliary cases, we perform 2 Whipple's procedures, 2 liver resections, 3 gastrectomies, 6 cholecystectomies. They comprise of they were both wrap, open, and extended cholecystectomies. We perform colectomies and hemicolectomies, low anterior resections. 3 cases are performed. We perform pharyngeostomy and 1 proctocolectomy case. So the complex procedures like Whipple's and liver resections are regularly done. We also perform breast cases like modified radical mastectomies, electromer reversals, minor procedures like excisional biopsies, true-cut biopsies, chest and pectoral insertions are also commonly done. Supraclavicular lymph node biopsies, which are least invasive and are very important for the diagnosis, are regularly performed. Anesthesia type, general anesthesia, 48 cases had undergone general anesthesia, 17 in local, 5 in IV, and 2 in spinal anesthesia. Top diagnosis, we usually have long mass as a main diagnosis. Other cases are CA stomach, cholelithiasis or GV pathologies, CA rectum, and CA esophagus. We also perform vast thymectomy and surgery for SMA syndrome. Complex procedures. In Whipple's procedures, we did 1 SMA reconstruction and 1 was periembolic carcinoma. In esophaectomy, we usually perform VAD 3-phase esophaectomy, and there was 1 case of colonic transposition. Liver resection, we perform 1 right hemihepatectomy with hanging maneuver. There was 1 systemic right posterior sectionectomy, and 1 posterior was total proctocolectomy, where we created a ileal J pulse for a case of familial irreversible polyposis, and 1 was a case of VAD thymectomy. Minor procedures, usually there are excisional biopsies, true-cut biopsies, and chest and pectoral insertions. Endoscopy, there were 70 cases of esophageal endoscopy, 20 colonoscopy, 52 bronchoscopy, and 3 OGD and dilatation. Case of the month. So it is a 57-year male, a case of adenocarcinoma of lung, who had undergone 6 cycles of neoadjuvant chemotherapy. So in the city, there was enhancing mass, it was in the right upper lobe, and there was pretracheal paratracheal lymphadenopathy, but there was also a right supraclavicular lymphadenopathy. So it was the MC disease. PET-CT was done. Within the PET-CT, the supraclavicular lymph node had FCG uptake, and the vision was not so improving. So on 2022, we performed right upper lobectomy with right supraclavicular lymph node dissection. So this is a typical imaging of right supraclavicular lymph node and FDG uptake. So how we manage end disease? As this was entry region because there was an involvement of supraclavicular lymph node. In NGO disease, we directly go for upfront surgery. In N1 disease, we go for upfront surgery followed by adjuvant chemo. In N2 disease, we usually confirm by biopsy by EVOS or use before proceeding. In N3 disease, these are usually considered unresectable, which are found for definitive chemoradiotherapy followed by consolidated immunotherapy or targeted therapy. Management of N2 disease. Usually, we go for pathological confirmation by non-invasive procedures. Then we go for molecular testing like EGFR, ALK, and PD-L1. And according to the driver mutation present, then we can decide whether we go for new adjuvant chemotherapy or we go for chemoradiotherapy. N3 disease. If there is N3 disease, these are usually considered unresectable, but nowadays we usually tried our multidisciplinary approach to make it convert to resectable. Like if there is driver mutation like EGFR and all, third generation tyrosine kinase inhibitors combined with chemotherapy can be used before going for surgery or radiotherapy. If there are no driver mutation, we can combine platinum-based chemotherapy and PD-1 or PD-L1 immune check inhibitors. Initial radical surgery of the tumor and bilateral lymphadenectomy was attempted by the Japanese surgeons, but it was not associated with any survival benefit. So usually these cases undergo combined chemoradiotherapy, but chemotherapy followed by surgery can be contemplated if there is RD restriction possible and there is good survival benefit. Also, the RT restriction was possible and there was a lymph node in the supraclavicular lymph node, so we did entry dissection of the supraclavicular lymph node and right upper lobectomy. Now I present the audit of Department for Thoracic Surgery for the month of May. So total surgery performed was 63, major was 42, minor was 19, and 3 were intermediate. As previous, the female patients comprised more of our cases with 57%. Age distribution, as previous, there were 56 to 46 to 60 years group are usually the majority of our cases. And the majority of the patients are from Chitwan district and the surrounding areas. So we performed 5 gastrectomies, distal and total, 4 Whipple procedures, 3 low anterior resection, 4 lobectomy and pneumonectomy. We also performed 3 VATS and tracheotomy procedures. Minor procedure, we performed external biopsies, tuchus biopsy, supraclavicular lymph node biopsies, chest and pectoral insertion, debridement, came for manipulation and came for insertion. Anesthesia, majority of our cases undergo general anesthesia. Top 5 diagnosis are long cases, long muscle CA lung are majority of our cases. They are followed by CA stomach or gastric disease and followed by CA esophagus and CA rectum. We also perform cases of ovarian cancer, Hodgkin's lymphoma, Marzoli's ulcer, and hernia. The complete procedure we procedures 4%, including 1 where we did hepatic artery divestment. We performed 3 3-phase hysterectomy, 1 VATS pneumonectomy, 1 total vein reconstruction with Whipples, and 1 liver hepatectomy for hydrolysis. Our endoscopy process for 53 patients of esophageal gastroduodenoscopy, 15 colonoscopy, 50 bronchoscopy, and 3 OGD and dilations. Case of the month. She was 67-year-old female, presented with pain in the right hyperperitoneum for 1 month. On examination, there was no anemia, no icterus, or no jaundice. In our abdominal examination, they were soft and non-tender. Blood reports were within normal limit with total bilirubin of 1 and direct 0.2 mg per deciliter. But there was mean pancreatic duct was dilated to 4.5 mm, as we can see in the image. So CT finding was hypoenhancing lesion. It is important because the head of pancreas must, if malignancy are suspected, they are usually hypoenhancing. There is usually option dilatation of main pancreatic duct as far as found in this case. But usually we can also find a double dog sign, which was not present in this case. Then we go for the venous and arterial anatomy. Yes, there were lots of intervening fat vein between the lesion and the supramesenteric vein, suggests of tumor abutment. But there was no definite narrowing, contour irregularity or thrombosis, and the arc of contact was less than 45 degrees, so we could easily go for proceed with surgery. There was no involvement of any portal vein, and the arterial involvement was not present. Liver was also normal. So these are the usually CT findings. Usually, if there is any pancreatic carcinoma case, these are what we should see. If the how the lesion and if it's involved in the other structure. Yeah, usually we have to see for the anatomy of arteries and veins and involvement, and you usually also have to see the liver for if there are metastatic. So this is uh, a representative image for pancreatic heart. There is hypointensive as it has been labeled. Here I'm trying to show you about the involvement of the portal vein and the bile duct. Here I can see, you can see that the portal bile duct has been compromised. In one image, we can see that portal vein is also involved, and in another post image, we can see that portal vein is also involved. In the same image. This is the teardrop sign. Usually, if the veins are involved, then we can find this. Here we can see that the superior mesenteric vein has been involved, and the teardrop sign is present. But it's so here also we can see that SMB is involved, but SMB is not involved. Another image also showing the same pathology explaining. So usually in the I'm usually trying to focus on the arterial involvement. So if you have when you see the CT scan, we usually have to see how much of the how much of the vein is involved or artery is involved before proceeding with surgery. In the first image, we can see that less than 180 degrees is involved. In we can only see abutment. The second, more than 180, which is encasement. In third, the artery anatomy of the artery is destroyed. So most probably it is an invasion of the artery. So why we do MRI? In this person we did MRI. Usually MRI is important if to see the liver mets, because the liver is the main focus of the metastasis. So sometimes CT may not show that, but in our case, liver was normal. In pancreas, we have to see T1 and T2 case. In T1, usually it is if it is malignancy, it is hypointense, iso or hypointense, and in T2 it will be hyperintense. Here I have submitted one image of a liver metastasis, which is usually present with enhancement. So, so we perform reverse procedure with splenic vein reconstruction with PTFE graft. There is enlarged peripancreatic nodes, and enlarged peripancreatic nodes are resectable, but the distant nodes were not present. So, I had studied an article about post-Whipple's what to expect. So, even comparing the Whipple's procedure with and without the reconstruction, the 30-day survival and 1 year survival of patient with vascular reconstruction was 93 and 55.2% compared with non-vascular reconstruction, which was 96 and 83.5%. But if we can create arterial resection, then I think we will be winning in that cases. So if it's resectable and less than 180 degree of the vein are involved, even in artery, if artery are involved and if it's less than 180 degree, they are considered now the borderline and we can go for surgery. Thank you.
Thank you, Dr. Sojos. A few comments. So out of the audience, we can see that we have various aspects of the surgical management. Not only the thoracic surgery, a lot of advanced cases. I mean, complex cases of the hepatobiliary pancreatic surgery, out of which the two major liver resections were done. And also the pancreatic, the most important thing is the vascular reconstruction. One of the cases underwent the hepatic artery divestment or anastomosis also, I guess, resection anastomosis, which you didn't mention. And besides that, the same patient underwent the SMB resection and reconstruction as well. So that was done with the type 4 resection with the graft, and the synthetic graft was done. PTFE graft was used to reconstruct the portal vein. Significant proportion of this vein was involved, so we did. So you should have mentioned and inserted the video of that patient also, because that patient underwent the type 4 reconstruction of the portal vein. So it's very important for you to represent our department to insert those videos along in front of the audience. This is one point. So the message from the second part in the month of May is that we have performed various complex surgeries, not only thoracic, but besides that of major hepatobiliary and the GI part of the surgeries were performed. So one of the examples that we mentioned is the arterial reconstruction, that you get the message if the artery is borderline resectable for the pancreatic head cancer could be depending upon the nature of the portal vein or portal SMB confluence or portal vein SMB involvement, or depending on the SMA involvement, or depending on the common hepatic artery involvement. So there are three categories that we divide how we classify the borderline resectable. So in our case, that was the borderline resectable both for the arteries and the vein in the case that you presented, the Vatri group, right? So arterial, you mentioned that there could be just only abutment in the first picture that you said, less than 180-degree contact. So in that case, maybe simple SMA approach will be enough. Just simple Whipple's procedure with SMA approach will be enough. In the second, where you said the encasement, where the more than 180 contact, so that is the borderline resectable because of the arterial involvement. In that case, you have to do divestment surgery. So that is the rule of thumb. Divestment is done for those cases. In the third, where obviously there is the disruption, I mean involvement of some of the not only the inventricia but a deeper layer of the artery, then only the option would be the arterial graft. You have to reconstruct the flow either by the autograft, some arterial like splenic artery can be repositioned in between, or you have to take the PTFE graft, or you can take the venous graft. So whatever is the reconstruction for the artery. So that should be the message from you. So it's very good that in our hospital we performed with the PTFE graft the reconstruction of the portal vein SMB, a significant proportion. Thanks goes to the department also, Dr. Saga, Dr. Manoj, and whoever were assisting in this case. So then the patient was discharged without any much more complications. She had few minor complications, but no anastomotic leak, and everything went very good in this first case. Regarding the month of June, you did not mention what were the endoscopic procedures we did. Have you mentioned? I didn't see. What have you mentioned? Malidehina. Their slide mat here? So maybe I skipped number were there. So whatever. So you mentioned the message from the month of June was that you mentioned very well that generally the N3 disease is not considered for the surgery. The guidelines is the chemoimmunotherapy plus minus radiation therapy is the treatment of choice, depending on how much of the lymph nodes are involved. So chemotherapy plus radiotherapy, chemoimmunotherapy plus radiotherapy, or if driver mutation is positive, then TKI plus radiotherapy. These are the options of choice. But right now in 2025, late December, or in the early 2026, the management has been changed. So if somehow, if the PET scan shows the isolated metastases which are resectable, not only for stage 3 but even for stage 4. Hello, Baralman, I should know. So if there are the resectable disease, then we have to consider for the resection. So first, not upfront surgery, we have to go for the down staging either by whatever you said, chemoimmunotherapy or the driver mutation TKI, followed by we reassess with the local therapy in the form of either surgery or the radiation therapy is applicable or not. In our particular patient received 6 cycles of chemotherapy, and the PET scan showed isolated supraclavian metastasis to the right side. Besides, there was the mediastinal lymphadenopathy, which were resectable. So we considered for the surgery. So the message was clear. So even for N3 disease, surgery is feasible in combination with the other forms of the treatment. Right? So thank you. Any questions of anyone? See you back.